All right, so welcome back, everyone. I've been sitting. This is such a beautiful event. I really want to congratulate you all and thank you for joining us to make this happen today. I just have some very brief remarks. Before I do that, though, I was remiss in my thanking people, and that's the scary part, right? When you start thanking people, you're always afraid you're going to leave somebody out. So I left out my boss. And that, right, that could have consequences. So I want to clean that up. So ladies and gentlemen, I want to please give a round of applause and a thanks to the Board of Directors of the Community Health Worker Network of New York City. Whew, thank you, you saved my butt. And there's two individuals who arrived a little while ago that I also want to thank. One is Debbie Halper. Debbie Halper works with the United Hospital Fund. And it was the United Hospital Fund that gave us money 10 years ago, 11 years ago, to actually start the Community Health Worker Network of New York City. And they seeded us. They made it possible for us to exist. And here we are 10 years later. And Debbie, if you hadn't done it, we wouldn't be here. Thank you. So that was the beginning. And today, there's a gentleman here who I'd like to introduce you to. His name is Jim Nickman, and he came in later also. And again, without the generous support, both financially and in kind, from the foundation, from the New York State Health Foundation, none of this would have been possible. Jacqueline and Nick, thank you so much. All right. So have we figured this out here? Oh, okay. So part of what we wanted to do today is really to talk about these recommendations that we have created that are designed to advance the CHW workforce in New York. I understand you have a copy of it. You were given a copy of it when you walked in. Yes? Okay. Okay. If you choose to go green and don't want to have that much paper in your possession, it is available on our website. And if that is a priority of yours, I invite you to just return it to the front desk. They'll be happy to take it, and you can have electronic copies of it. Also, if you want to help distribute this and broadcast it broadly and widely, we invite you to let people know that it is available on our website. That is at chwnetwork.org. So we wanted to explain to you what some of the work that we've done over the past 2 years and some of the process, because we've really been told by many of our colleagues across the country that this is perhaps the most sophisticated and contemporary treatment of this issue that they've ever seen. And these are really like national leaders, people who have been national leaders in the CHW development for many years. And so we wanted to share a little bit of that process with you. We had, I'm sorry, Jackie had to leave. Jackie, I got to tell you, Jackie works in Washington, D.C., and she had to teach a class tonight. And so she had to leave a little early. So it's really a huge statement that a national spokesperson like that, would take the time to get on the train early this morning and come down here to be able to speak with us, knowing that she has to jump back on the train and head back to D.C. for a class tonight. That's amazing. So I wanted to thank Jackie before she left. So Jackie would have been happy to see that we had 4 points that we wanted to cover in this project, which started about 2.5 years ago. Lisi and Robert and the crew at the Docanto Group and Rabin Groups were very strong with us in telling us that we had to define a purpose, a message, a vision that would lead us throughout this enormous effort, because they were very clear that we could easily become distracted from that vision if we were not nailed to it. And so through much sweat and tears, we finally arrived at the fact that our purpose for the next 2 years was going to be to advance and sustain the CHW workforce in New York State. To do that, as we told you this morning, turned out to be large. And it involved the 3 issues that you see up there. One of the other big thing that we told you about is we knew very early on that we would have to engage leaders, decision makers, first leaders in the state of New York very early on, and engage them in a way that they would be, they would be able to contribute and support these efforts. And so we did reach out to the major employers. The health department, the New York State Health Department, is perhaps the largest employer of CHWs in New York State, as they have their maternal child health programs. They have a CHW program within the maternal child health, chronic disease management, HIV and AIDS. The AIDS Institute has a lot of CHW. So we reached out to all of those major employers, both private and public sectors. We reached out to financiers, payers, insurance companies, providers themselves, and formed this leadership advisory group. The important thing about the leadership advisory group, which goes along with all of our philosophies, was that it includes CHW leadership. And as Jackie Scott was so eloquent about, that is really critical. Without CHW leadership, who knows where this would have gone. So that was important for that. I also, when the leadership advisory group started working, and they quickly realized that there were 3 aspects to this project, they formed work groups. And the work groups were made up of members of the leadership advisory group. So, these are busy people. These are like top leaders. So it was really astonishing to me to see that much energy, that not only were they willing to come down to the city and have a meeting every couple of months, but here they were wanting to participate in a work group, really roll up your sleeves, get dirty, and do some work. And so that was really an amazing thing to us. As we formed the work groups, we realized that each work group needed to be chaired. There had to be a principal person responsible for it. And so it was decided that each work group would be co-chaired by one of these leaders and a CHW. So CHWs, in a very genuine and authentic way, really participated in the leadership of this effort. And I think that has a lot to do with its amazing success. In addition, we realized that this had never been done before, at least not in this way. And so we assigned staff to support the work of each of the working groups, so that the working groups could really focus on being creative and innovative and not have to worry about the support stuff. We assigned people to do that. And I'm going to talk to you a little bit about that in a hot second, because that turned out to be a huge amount of work too. And then lastly, we knew that a lot of these efforts were not local, that what we would come up with at the end, down the road, would have statewide implications. And so it wasn't just something that the CHW network of New York City could undertake. It really had to have statewide or more broad representation of CHW leadership and stakeholders. And so in the midst of all of that, we knew that we had to undertake some efforts to go to other parts of the state and beat the bushes and really find some CHWs and help them organize and really build the groundwork so that we could establish this statewide CHW association. We did a lot of work in Buffalo until it got really cold. And I haven't been back since. I'm sorry, Mark. Yeah, I don't know how you guys do that. But yeah, Rochester ain't too much hotter. I know. Yeah. I know. I remember I went up to Rochester when I was freezing. It was incredible. And Lucia walks out in her little jacket, like it was nothing. Well, you got some rugged people up there. All right. So the first thing that we were challenged with was, of course, a community health worker scope of practice. And again, respecting and recognizing the diversity and the richness of this workforce and the many different things that CHWs do, we wanted to be respectful of that diversity and really embrace all possibilities. And so it really became a rough way to go. The work group actually demanded that we asked us for some data, some information that didn't exist. And so we actually had to undertake some original scientific research, and Sally led most of that, to really actually gather this information for them. And not only did we have to do the original research, we had to do the data analysis, we had to write it up, we had to presented in a way that made sense to people. So, again, it seemed like everything we tried to accomplish, we took on 3 more jobs. So it's really impressive that we've come to this day. It was a lot of the work in the scope of practice was also based on the original national campaign that we led. We, the CHW network here in the city, led this national campaign to have the Department of Labor accept us as a unique standard occupational category. And so a lot of that, the efforts that went into that and the data gathering and the advocacy package that went into that were very useful in this effort. Okay, and then, so we did interviews, we did key informant interviews, discussion circles, we did this thing called a participatory ranking methodology, which was a lot of fun and did a lot of support for us. But most importantly, we were encouraged by actually a national CHW consultant to do a functional task analysis. And can I have the next? Man, was this a job. We hated this guy, but it was really, we talk about roles and tasks and skills, and we're soft and mushy with it. We don't really, what it really is a task, what's its role. Well, the functional task analysis really helped us to really tease that out and be sure about like what is a role, what is a task, and what is a skill. And we really needed to get to the skills so that we could think about training. Right? Without that, we couldn't do it. So there was a lot of confusion out there about what is a role, what is a task, is a skill. So let me explain the way, for the purposes of this functional task analysis, a role is a large purpose, a bigger thing, the big thing that you want to achieve. A task is a set of activities that you engage in to achieve that role. And a skill is a proficiency, a capacity that lets you conduct the tasks so that you can achieve your role. I know it sounds simple, but that really helped us because in our research, people were telling us, we would ask people, what do you do? And they would tell us, we had 28 different elements or something of what people did. So it was really difficult for us to tease that out. This functional task analysis was amazing for that. Not only did it help us tease that out, but it also provides, you actually, for each role, you actually have to figure out a task statement. And then for each task statement, you have to figure out what are the outcomes, what are the performance variables, and what are the coordination and supervision issues. So we really, this is amazing because, we don't have this stuff. So we were able to generate it through the functional task analysis. What came out of that effort, or out of the combination of all of those huge efforts, was a CHW scope of practice. And here it is, hot off the press. This scope of practice is informed by all stakeholders. CHWs, their employers. CHWs told us this is what we do. Employers told us this is what I want to pay for. This is what I want my employees to do. Financiers told us, payers told us this is what we'll put money on. Okay? So this is what the world wants. This is really an amazing piece of work. I talked. Well, okay, I'll talk about that in a minute. There are some very contemporary nuances to this scope of practice that I want to highlight for you. One is if you look at the last one, health promotion and coaching, many people used to call that health educators, health education. But over the last couple of years, health education has really come to mean something else. It's a task that many different people could do. It's not really a role. You don't do health education just to do health education. You do it for a larger purpose, right? And what is that larger purpose? What is that role? Well, CHW's told us that for them, in many other parts of the universe, health education has come to mean clinically accurate materials, like creating clinically accurate materials and disseminating that. CHW's told us that's not really what we do. That doesn't fit right. So we asked them, so what is the larger purpose for which you do health education? And what we were told was we promote health. We're health promoters. And we're coaches. We don't go out there hammering clinically accurate materials into people. We have a shared life experience and we coach people. We're kind of a role model, a peer model. And so that really, we circulated that a little bit and tested it with people, and people said, yeah, this fits. This fits. I like this. And people sort of embrace that. And so what I do is health promotion and coaching. Yeah, that worked. The other big one is the second one on your left. I always have a problem with that. Which used to be, some people used to call patient navigation. Patient navigation, when that law was originally written, it was designed for community health workers. That was its purpose. But then when it got funded by the feds for patient navigation, a lot of other professions took it on because there was federal funding for it. And they have pretty strong lobby groups, which we don't have. So patient navigation, you know, a lot of people do it, right? Nurses do it, doctors do it, social workers do it, everybody does it. And so CHWs were feeling, that's not really our purpose. We don't just do patient navigation to do patient navigation. We do it for a larger purpose. And what is that purpose? We have to tease that out. And so what people came up with was that we don't just do patient navigation, we do system. We do system navigation. We help systems become appropriate to the people that they're supposed to serve. And we help people access the system in a way that's appropriate for them. It's a two-way system navigation purpose that we conduct. And so that seemed to fit better. So just, I don't have we're not going to go into the details. This stuff is all in your fancy report there, and you're welcome to distribute it as broadly and widely as you wish. We would appreciate that, actually. The last one I want to pay particular attention to is this last one on the bottom here, participatory research. That is an emerging, a new and emerging role for CHWs to be involved in research. Many people are realizing that because of the unique access that CHWs have, and because of the trust that they have with the people that they serve, that they have access to some truths that not many other people do. And truth, you must know, is pretty important when you're doing research, or at least accuracy. And so that's a new and emerging role that CHWs have embraced. The really interesting thing about this work was that, I mean, not that the scope of work was not interesting, it was fantastically interesting. But when we looked at all the data that we had gotten, and after we did this functional task analysis, there were a number of elements that didn't quite fit. You know, it didn't fit into this labor market tool, but there were things that employers, I mean, there were some of the first things employers would say. When we would ask them, what do you look for in a CHW? What does the CHWs do? These things were like the first things they would say to us, and yet we weren't able to fit it into this tool. And it was, and when we asked CHWs, what do you do? This is often the first thing they would say. But, you know, but when you do this labor analysis stuff, you know, you can't sell love, you can't, you know, commitment, you know, people don't want to pay for commitment. So we couldn't figure out, like, what were these elements, right? And as it turned out, these are attributes. These are like qualities. This is our soul. This is like what makes us who we are. And it doesn't fit into a job description. It doesn't. It just doesn't. You can't buy this stuff because it's human. It's spiritual. It's you. It's your soul. And it was amazing because once we created this list, then employers told us, oh my God, that's what I need. That's what I need to interview people for. And CHWs knew, you know, CHWs would tell us, oh, this is really helpful for me to try to figure out if this is a career for me, if I want to pursue this. So this is really, this is an extraordinary, our ability to document this is really extraordinary. These are the qualities that lead to success. If you want to run a CHW project, these are the qualities that would lend themselves to you being successful. If you want to train anybody in here who's a training institution, let me speak to you directly. If you want to successfully train CHWs, you might want to look for these things before you start training people. This is not my opinion. This is the opinion of the CHW labor market. This is what employers want, and this is what CHWs want to do. Okay, so DC hasn't told me to get off yet, so. So the next big task was CHW training and credentialing. And I'm going to tell you that our recommendations around CHW training and credentialing are informed by all existing experiences, including the mistakes, the gregarious mistakes made in Texas and Ohio. And so we've learned from those mistakes, and we've learned not to do it that way. Our products, the products of this work group are very exact. They tell people who are interested in training CHWs, there are recommendations for what you should be training us in, the content of our training, the methodology, the pedagogy that would be appropriate to train CHWs with. It makes recommendations about how do you develop training and how do you deliver training. In particular, those recommendations call for CHW leadership in both training design and training delivery. So again, very, very exact, very discrete recommendations for institutions that are looking to train CHWs. The big force, with the reason why these recommendations in particular were so exact and so precise, is that there is a very clear and evident danger that academic institutions have the power to really alter the character of a workforce. That has happened many times. You know, people who go to social work hard to get through a master's program in social work. They don't do that to fill out forms for the rest of their life. They had a different purpose when they started that. But between the academic institution and the financing of social work, they have to work, they have to complete forms all day to get paid. So we were really we were careful about the power of existing organizations out there, and really wanting to provide guidance for them so that they could be informed and conduct their duty appropriately. Here he comes. In our surveys, I will say that 100% of the CHWs we interviewed, and we interviewed hundreds of them, told us that they would like to complete a training if there was training available in core competencies. 71% said they would pay for it if it was under $400 and if it was available. And 80% of employers told us that they would use standardized training for CHWs if it was available. So again, this is in response to the labor market. One last thing, Lisi, because this was the big enchilada, right? We started talking about financing. And the reasons why we wanted to develop financing are clear. But let me just say that there is a very strong business case, and some people alluded to it earlier this morning. The return on investment for CHWs is really, the evidence on that is really emerging very rapidly. Andy Nieto talked about his return on investment experience in Presbyterian Hospital and how that enabled him to move CHWs from grant soft money funding to the corporate budget. By and large, the ROI, the return on investment numbers are coming around 2 to 3, or 2 to 4. Somewhere, for every dollar invested, you get back somewhere between $2 and $4 is the way it's turning out. We had some extraordinary experiences, like a company in Georgia that has a very diverse portfolio, and they have one CHW. They have 1,100 employees, I think, yeah. They have one CHW. They are fully self-insured for health and workman's compensation. So they're invested in the long-term health of their employees. And this one CHW, they do lumber, a lot of lumber. They do everything from cutting down trees to making fine furniture. This one CHW, they've estimated, has saved them over $24 million in 9 years. One guy, yeah. So the evidence base is it's clear, it works, it's attractive financially and ethically and morally. So that's the top set of bullets. The products, I want to talk about a little bit about the products, because the products were really designed to meet the current needs of the evolving healthcare financing system. So we don't talk about fee for payment anymore, because that's dead in the water now. That's not where this state is going. And so we really talk about things more like shared risk, payment for outcomes, developing network partnerships, and the things that will be rewarded and incentivized by healthcare reform. You know, when Medicaid redesign and PCMHs and everybody who's making these new innovations, they're going to get a chunk of money, and they're going to have to pay everybody with that chunk of money. Now everybody knows you're going to need a doctor, and everybody knows you're going to need a nurse. But then who else do you need? Amen. So that's your call to action. as the Honorable Assemblyman Gottfried said today, our call now is to help people understand, to let people know, to help people know that your system is not going to work. You heard him. The system is not going to work without CHWs. The system is, that's our message. You could spend all the money you want. You could be as fancy and as cute as you want. The system is not going to work without CHWs. All right.